Hi, my name is Kate Sullivan, and I'm representing the Medical Advisory Board of the Immune Deficiency Foundation. Today, on March 18th, the topics that I am going to cover are an update on treatment that I think you will find interesting, specific concerns for people living with different types of primary immune deficiency, vaccine development, and then I will end with a link for an interesting video on why we touch our face so much. So to begin with the update, I would like to talk about vaccine development and drugs that are being utilized to treat COVID-19. All of these are experimental, but I think there is an interesting twist to the treatment that people with immune deficiencies will find particularly interesting. So the treatments fall into several categories. So the first category is a treatment that has been utilized for ages and ages, and that is to use antibodies to the virus to treat people who are acutely ill. This was first piloted in China, where they took plasma from people who had recovered from COVID-19 and gave it to people with the active infection, and it is now being produced pharmaceutically so that it could be given to large numbers. There are no data on efficacy yet for that particular treatment, but it is a very time-honored treatment for acute infections, literally dating back to the 1920s. The next category I would like to talk about are direct antiviral agents, and I'm going to start with a drug called remdesivir. This is in active trials right now. People are being treated with it. The initial results do look quite promising, but the actual study results have not been reported out. This is a drug that was developed to treat Ebola, and it actually didn't work especially well for Ebola, but it has been shown to work in a related viral infection, and so there is high hopes that it will work in COVID-19. Next among the antivirals are two drugs that were developed and are currently being used to treat HIV, but the mechanism by which they work is thought to possibly also be effective for COVID-19. And those drugs are in trial. It is a fixed drug combination of lopinavir and ritonavir, and those drugs are also in active ongoing trials at the moment. There's another drug that is often used to treat autoimmune and inflammatory diseases called hydroxychloroquine. It's actually a very safe drug and has been used for decades and decades. It seems to work in vitro in a test tube, but it's unclear if it will work in people, and there are active trials going on in France right now to test its efficacy. Finally, the category that I think you will find most interesting is the category where the actual immune response to the virus is altered. This is a theme and a concept that is very familiar to people living with primary immune deficiencies, and so it's worth just spending a moment to talk about why that might be effective and why people are trying it. So when the immune system responds to a virus, and I will talk more about this in a minute, one of the most aggressive phases is when the T cells respond to the virus and begin to expand and multiply and proliferate. One of the most aggressive responses to viral infections involves CD8 T cells that recognize the viral infection, expand and proliferate, and they send out cytokines. Cytokines are basically the hormones of the immune system. They're signals that tell the other cells what's going on. And these cytokines are meant to be a form of communication in the immune system. But they can get produced in very high amounts, and in that setting, we refer to it as hyperinflammation or sometimes a cytokine storm. And that can be harmful in that it causes the fluids to leak out of the blood vessels, and that's some of what we see in people with COVID-19 who have very severe lung disease. Now, there's multiple reasons to have very severe lung disease in COVID-19, but there's a sense that in some cases it's due to very high cytokine levels causing this leakage of fluid into the lungs. So there is an active trial to use a drug called tocilizumab. Tocilizumab is an antibody that blocks IL-6, one of the primary cytokines involved in this hyperinflammatory response. The initial results from China look very promising, and there are ongoing trials. The reason I mention it is we usually think of dampening the immune response or people having inborn problems being able to respond to viruses as being unusually susceptible. But here's an example where it actually facilitates recovery from the virus. I did want to mention that because I thought it would really resonate with people living with primary immune deficiencies. I'm going to back up now and just talk for 1 minute about how the body responds to a typical virus, including how we think it responds to the SARS-CoV-2 virus that causes COVID-19. So initially the virus will land on a surface, usually our nose, our eye, the back of our throat, and that virus starts to reproduce itself, and that is called replication. Viruses reproduce very, very quickly, in the order of minutes, not hours, and so viruses can hijack the machinery of the cells in the back of the throat or in the nose for their own purposes in order to reproduce themselves. They reproduce locally and then at some point usually spill into the surrounding tissues or even into the bloodstream. So in the case of COVID-19, this initial phase lasts 5 to 7 days usually. And at that point, antibodies begin to be made, and also the T cells recognize that there is a viral infection and begin that phase of proliferation, making more of themselves. The idea is you want as many soldiers as you possibly can to fight a viral infection. So the T cells literally make more of themselves. But they also send out these inflammatory messengers called cytokines. And that causes a lot of the fever, and it causes the part where you just don't feel good. This is generally true for most viral infections. The T cells then begin to attack the virus, but because the virus is inside of our own cells, that means killing our own cells to get rid of the virus. I'm going to transition now with that little bit of foundation, and I'm going to talk about specific categories of immune deficiencies and what we think their vulnerabilities will be. I'm going to say again that this is largely theoretical. There are almost no reports of immune deficient patients coming from China or Korea yet where we can assess the true risk. You will be pleased to know that the Immune Deficiency Foundation, along with the International Union of Immunological Societies and all of the continental societies for immune deficiencies, have banded together to try and collect this information, but it will still be several weeks before we have the results. In the meantime, I did want to provide at least some theoretical reasons to think about different categories of immune deficiencies. So to start with, people with antibody deficiencies. So this would be all of the people with A-gamma globulinemia, the people with common variable immune deficiency, although there's a particular asterisk for them, and all of the people with hyper-IgM, all of the different types of hyper-IgM. In the setting of antibody deficiency, at this moment, we do not think the risk is any higher than the general population, unless there are additional complications like significant lung disease. Asthma on its own is not thought to be a significant risk factor for severe disease, but structural lung disease is. I will say common variable immune deficiency can be associated with low T cells, and as always, you want to communicate with your immunologist about your particular risks. But just as a broad framework, at this moment, we do not think people with antibody deficiencies as a big category are unusually susceptible to the virus. The next category I want to talk about are people with significant T cell deficiencies. Now, this could apply to some people with common variable immune deficiency. It can apply to a whole host of immune deficiencies like Wiskott-Aldrich syndrome, like combined immune deficiency, like DeGeorge syndrome. If your doctor has told you that you have a significant T cell immune deficiency, they have probably also told you to use any and all methods to avoid being infected, because remember, it's the T cells that we think are important for the clearance of the virus. The last category I want to talk about are people with phagocytic defects, so people with chronic granulomatous disease or neutropenia. Here the risk is less about the virus and more about the susceptibility to bacterial superinfection. So I'm going to end with a bit of good news. So in addition to therapies for COVID-19, there is abundant work going on to develop vaccines. And you may have seen that the very first person to be tested for a COVID-19 vaccine was in Seattle just a few days ago. There are multiple efforts to develop a vaccine. None of them at the moment are live viral vaccines. They are all some combination of subunit vaccines or purified protein components. As far as I know, there's no efforts to develop a live viral vaccine at this time. As you no doubt have heard on the news, vaccine development is very slow. Just because the first person got the first test dose does not mean we are months away from having a vaccine. Tony Fauci of the National Institutes of Health has estimated that we are still a year away. Why would it take so long? The first phase in vaccine development is safety. That's what's going on right now. The next phase will be to test efficacy. That means vaccinating people who are exposed or have a potential exposure and asking how effective it is at diminishing disease. It's worth a reminder that not all vaccines are effective. There are any number of failed HIV vaccines, and there are 2 examples of vaccines that were developed that actually caused increased disease when people had the virus in question. So this is not a step to be taken lightly. Just because a vaccine produces antibodies does not mean that it will be clinically effective. All of this takes time, money, and people, and that is why the estimate is that it will take about a year to develop a vaccine. But on the more optimistic side, there is lots of effort, money, and brain power going in to develop a vaccine for COVID-19.